Then we are live in 3, 2, 1. Please start. We are live.
Namaskar and good evening, everyone. I welcome you all for today's webinar on Lung Cancer Treatment Updates 2022. And with immense pleasure, I would like to invite Dr. Manish Sharma, who is Consultant and Head of Unit Medical Oncology, Rajiv Gandhi Cancer Institute, Delhi, to set the ball rolling and to take the proceeding further. Over to you, sir.
Hi, good evening, everyone, and pleasure to invite you here on this evening. And we all would be discussing today about few of the lung cancer updates in 2022 and what we have new. So lung cancer is the most common cancer worldwide and probably the cancer with the highest mortality after pancreatic cancer. And the most of the time the patients, they will come in stage 4. Very few nowadays patients have started coming in stage 1 to 3 as well. So till the few years back, the role of NGS and molecular testing was just limited to the stage 4 cancers in our clinical practice. But nowadays, so we have much of the data in early stage lung cancer also, of various targeted therapies and immunotherapies being used post resection. So we will be discussing about the role of these treatments and role of diagnostic testing in early stage and later stage lung cancer. So the agenda is that none other than Dr. Arpana would be speaking about role of NGS. Then we'll be talking about various molecular therapies in lung cancer. Then Dr. about early stage lung cancer, and then Dr. Praveen would be dealing with panel discussion on early stage Nsclc. So I invite Dr. Arpana. She is head of department SRL Renvexi, medical counseling and medical genetics. She is well-known figure in molecular biology, and I invite you, ma'am, here for your talk, the role of NGS in lung cancer. Over to you.
Right. Good evening, everybody. Thank you, Dr. Manish, for the very kind introduction, and thank you for having me here today. So for the next 15-20 minutes, I'm going to try and illustrate the importance of NGS and molecular profiling, and particularly in lung cancer. So let's get started. Now, we know the field of oncology, it has evolved. We've gone from an era where it was all about understanding what permutation combination of chemotherapy should we use, and irrespective of whatever we did, and there were seminal studies in the British Journal of Medicine and Nature publication, the overall median was, overall survival was abysmal, around 7.9 to 8 months. And it was around the same time that, journals started reporting the first draft of the Human Genome Project. And it's now that we began to understand the human genome, could we actually come to appreciate the cancer genome? And as we studied lung cancer, we began to understand the various oncogenic driver mutations, their genetic aberrations, combined with the data from the Human Genome Project, which actually helped us chalk out potential targeted therapies. Now, the tyrosine kinase inhibitor pathway, we know, has revolutionized the way that we treat our patients with lung cancers. EGFR, ALK, ROS1. We know our patients, when they get molecularly matched with a TKI, they respond far better than our chemotherapy. And in order to support this today, we have a variety of platforms and technologies like FISH, IHC, PCR, and NGS. Now we know that NGS is fast becoming the popular platform of choice, and to help call out these biomarkers, and it's making us, it's helping us with, guiding treatment options, which in turn actually is, where it's actually improving the median overall survival of our patients. So what have we learned about lung cancer? We've learned that's possibly one of the most molecularly diverse cancers. If you just look at the Nsclc cohort in particular, just see how it's evolved. You've gone from treating Nsclc as one large homogeneous group to slowly, we moved on to categorizing it based on its histological subtypes. And if you just look at the adenocarcinoma subtype, it's really molecularly diverse. And I wouldn't draw your attention to this greater than 1 mutation, 3%, one oncogenic driver mutation. This actually constitutes for 3% of our cases. And I want you to keep this little one in mind because I'm going to revisit it in a bit. So what does our landscape look like for us? So here is a screenshot of the most recent NCCN guidelines. Gone are the days when it was just about EGFR, ALK, ROS1. You've got a plethora of biomarkers that is highly recommended, and not just for the adenocarcinoma, even for the squamous cell carcinoma. So upfront, it is recommended. So we are very familiar with these biomarkers. We've heard about them time and again. So I'm not really going to spend too much time talking about them, but I want to bring your attention to this very beautiful pie chart that very nicely highlights all the somatic aberrations, that we see in the adenotype of Nsclc. And while Keras is very common, particularly in our smoking cohort, there's a wide variety of somatic aberrations. And if you see, I use the word aberrations, right? That's because some of them could be fusions, some of them could be point mutations. So there's a variety of structural variants, and hence my word somatic aberrations. And majority of these are easily druggable by a variety of drugs. And what this actually does is it actually allows us to classify our tumors into what I like to call the bigness guide to targeted drug therapy. So you've got those tumors that are oncogenic addicted. All you need to know is what is the particular driver mutation, you molecularly match it to the drug. But then you have those where it really doesn't matter, what the mutation is. That tumor is addicted to immunotherapy. And when you get it right, it really works wonderfully. So this was a 59-year-old female, EGFR positive. She was put on Jactamine. The patient showed remarkable response and reports to have, overall quality of life was far more better. Now, one very important thing about these molecular targets is that they're highly effective, but they're not always curative. Now, let's very quickly review, our sample options, that we have for molecular testing. Now, we know tissue biopsy has always been the gold standard. There's no argument there, right? You do a biopsy at diagnosis, at progression, you do a biopsy, preferably from a new metastatic site. However, the ground reality is that while we like our blocks looking like this, tissue does become an issue. And to combat tissue being an issue, liquid biopsy is a very, very good alternative. So in stage 3B and above lung cancer, you can actually isolate the ctDNA, the circulating tumor DNA, from the bloodstream. So your ctDNA is the somatic DNA that is released from the cancer cells into the bloodstream. And the ctDNA is isolated, and on that, the molecular tumor profiling is done. So one of the key apprehensions, the concerns that we've always had around liquid biopsy was its concordance with tissue biopsy. And, the Nsclc Penn studies where they've actually used clinical samples of patients with Nsclc, they've used as biomarkers, the 7-8 biomarkers that are recommended by NCCN, and they saw a concordance between tissue and liquid of around 98%. In addition, liquid biopsy did have a couple of pros where it kind of slightly trumped over tissue biopsy. Now, because it's non-invasive, you can actually, 1, monitor the treatment response, 2, monitor resistance mutations, and 3, it addresses the issue of tumor heterogeneity. And this is something similar, that was being addressed in the IASLC consensus statement that was led by Dr. Christian Rolfo. And we were reminded that, there are some key differences between the two. So with tissue biopsy, of course, you get the cancer diagnosis, the pathology information, and an assessment of markers like PD-L1 that is, non-genomic. However, there's a lot of good data and work coming out where they're using circulating tumor cells, using the concept of flow cytometry for actually calling out these PD-L1 mutations on liquid biopsies. And exciting work happening there. But, we know that, of course, all of this, it's challenging to repeat biopsies, and, and biopsies are also not are not reflective, of tumor heterogeneity. So liquid biopsy is found to be highly concordant. It's fast. We know it's minimally invasive, and it's very easy to repeat over time, and perhaps better to capture tumor heterogeneity. But this consensus did say that, you know, it doesn't have the exact 100% sensitivity of tissue, but it's not inferior either. So this is what they are recommending, you know, in the clinic in treatment-naive patients that you know, that there are 3 approaches that they're recommending for liquid biopsy. The first one is a sequential approach where the tissue testing has failed, so you send it in for a liquid biopsy. The second is a complementary approach. And honestly, when cost is not an issue, I think this is a fantastic approach where you do both upfront, tissue and liquid. The third is the plasma first approach, where it's, you know, where you know, when you're very sure that there's not going to be any sufficient tissue, surgery, biopsy is not an option, and tissue is not accessible, then you do liquid biopsy upfront. Now, for these biomarkers, you know, there are many validated platform technologies that are available to call out the variants, but NGS is my preferred platform. Now, I'm not going to be belittling the standard of care of platforms like, you know, your RT-PCR, your FISH, IHC, because I feel with NGS, that we get the answer to the tumor biology. I think today when we treat cancer, it's not just about these biomarkers, it's the biology of the tumor. While some of the genes, some of those oncogenic driver mutations may not have a targeted therapy, but they actually have prognostic value, or it helps you understand the biology. Is this TP53? We know the presence of a TP53 is going to prevent or not allow my patient to have the ideal response to a TKI. It inhibits an EGFR mutation. So information like this is something that NGS can give you in one shot, in one sitting versus, you know, your standard of care platform. In addition, what's happening is that NGS is also proven to be cost effective. The cost has come down. You know, you've got an improved TAT, at least a basic lung panel, which the 12 odd genes of importance. You get a result in 15 days. Tissue preservation, irrespective of using Thermo Fisher or Illumina, you need some good quality 20 nanograms to maybe 100 nanogram DNA. But the key point for me is that where I truly feel that, especially in lung, which is such a molecularly diverse cancer, where NGS trumps the standard of care, is it has the potential to discover more actionable targets. So you're going beyond the EGFR exon 18, 19, 21, or even within those exons, you have the capability of calling out those rare novel mutations. And the pie chart that I'd shown you earlier, where I said there was a possibility of having more than one oncogenic driver mutation, which is 3%. 3% we think is, oh, it's a really small number, but in sheer volume for a patient care, that 3% actually helps, you know, call out and helps you as oncologists design as to what would be the best treatment option for your patient. And all this gets done in one go. So you're actually helping guide and chart out a more personalized treatment for our patients. And why here, this is a very simple data set that is from my personal clinic. And why we have 38.9% actionable targets, alterations. What was very important are the concomitant genomic alterations that we're seeing over here. EGFR, we know different types of EGFR mutations respond better to a different type of target. EGFR with TP53, EGFR with Keras, EGFR with ALK. All these mutations simultaneously actually help us make very informed decisions as to how we're going to look after our patients. Now, this is an incomplete data set, but just, you know, something within those 10, 12 genes of importance, what we've identified. Now, moving on to, you know, just, I can give you our data, but let me just use two biomarkers that we're very comfortable with in our practice. So to further illustrate as to why I think NGS is a really, really important platform in lung cancer. So in an unselected population, you identify, let's say, an EGFR mutation, you put your patient on a TKI, you know that after a period of time, it does develop resistance, and, you know, we use imaging to confirm it. Now we do a rebiopsy, and preferably from the new metastatic site, or if rebiopsy is not an option, we do a liquid biopsy. Irrespective of sample type, we send the sample for molecular profiling. Now we've identified that the most common resistance mutation to EGFR is the T790M, and it accounts for around 60% of these cases. But in addition to this, we also have a host of other resistance mutations. You've got your MET amplifications, you've got your PIK3CA, your HER2, and more importantly enough, your small cell transformations. Similarly, you know, when a patient progresses on osimertinib, it acquires resistance mutations. And again, you know, we saw this in the AURA3 trials. that, that around 15% of these patients get a C797X mutation, and that's about 19%. So, then you've got those that are positive for a MET amplification, HER2 amplification, which is around 5%. And all of these mutations can be reported in one go using NGS as your platform of choice. And similarly with ALK, it's not all about being ALK positive, it's about which is the fusion partner that is with ALK. Is it a point mutation? And accordingly, if a patient's progressed on, let's say, crizotinib, which type of mutation? Now, crizotinib G1202R is a very common mutation. We know if my patient has that, I'm not going to, I'd have to change therapy, maybe for the patient's serotinib or lectinib or on which it would possibly respond better. And all this can be done using next generation sequencing. And for me, this is where we are in 2022. Look at the plethora. I mean, there's a plethora of biomarkers, and we can see there are a couple of new additions. So we're very quickly going to talk about them. I've got my NTRK fusions. We know they're rare. They constitute for around 0.3% of our Nsclc cases. These are agnostic markers. And we see from these waterfall plots that entrectinib, larotrectinib, that across the board, across all solid tumors, lung cancer included, our patients do respond really well. Then what essentially are we looking for? So in NTRK is essentially the rearrangement of the genes. It's a fusion partner, and the most common fusions that we see in Nsclcs, NTRK1 is with TP53, CD74, TPM3, three very common fusion partners, and in NTRK3 we see the ETV6 and the EML4. So how do we test this? Being a fusion partner, ideally, I know ESMO talks about ESMO talks about using FISH and IHC, but in my very humble opinion, I think it's just better that we stick to NGS because it's got a far more higher sensitivity, and RNA NGS because we know anytime you're looking for a fusion, be it ALK, ROS, MET, any fusion across the board, RNA NGS is your platform of choice. If your service provider gives you a report and it's negative, I think it's important that you go back, check with your service provider and say, my NGS report is negative for an NTRK mutation. Is it a true negative? Have you done DNA or RNA NGS? If they say they've done DNA NGS, I very strongly recommend doing an RNA NGS. Now we talk about RET. RET is, we know, synonymous with papillary thyroid carcinomas, but it actually constitutes 1 to 2% of Nsclc cases. Again, RET gene is a rearrangement, it is a fusion, and the most common fusion partner we see in our Nsclc cohort is the KIF5B, and this is followed by the CCD6. I'm talking about Nsclc in particular. Again, it's a fusion, so for me, I think NGS is my preferred platform of choice. My therapy options are selpercatinib, which is what we get from the Libretto 001 trials, and pralsetinib, which is from the ARROW trials. Then we move on to the MET exon 14 skipping. Now, it's a mutation that occurs at the junction of exon 13 and exon 14, and this leads to the skipping of exon 14, and the product is a fusion partner of exon 13 and exon 15. Again, a fusion, so it has to be RNA NGS, and your therapies of choice is crizotinib from the Profile 101 trials. You've got capmatinib from the Geometry trials, and you've got tepotinib, I think, from the Vision trials. Then we move on to Keras, right? This is one of the latest additions to the biomarker circuit. Now, it's one of the most common cancers in Nsclc. They constitute for around 25 to 33% of cases, especially in our smoking cohort. So what you're doing is you're essentially looking for a mutation in the GTP binding protein that connects the receptors of the tyrosine kinase. Now, from this subtype, G12C is the most common. It constitutes for around 40% of these Keras cases. And what's interesting in this particular subgroup are the varying TMB rates. So G13 has a high TMB followed by G12C, and G12D has a propensity for a lower tumor mutation burden. Even the PD-L1 rates are high, with a high TPS score is what we see in the G12C and the G12D. And we use NGS as our platform of choice. But in this case, maybe RT-PCR, if you're just looking for Keras, can be done, but NGS is my preferred platform of choice. So Tyrosine is my therapy of choice from the Amgen trials. And we talk about immunotherapy because this talk would be incomplete. Keynote 010 and Checkmate 017 Oak trials, they've demonstrated the utility of PD-L1. We've got three clones 22C3, which is on DACO, SP263 on Ventana, and SP142 on Ventana. You look at the TPS score, you see if the patient is a candidate for immunotherapy. Similarly, we have something called Chemomutation Burden. I personally think it's slightly controversial as an immunotherapy biomarker, especially in lung. So the key theory is that every cancer's got a mutation, and more the mutation, higher the neoantigen load, and possibly a better immune response. So in the lab, on a minimum 250 gene panel, you look at the number of genetic aberrations that are there, in the exonic region, and this gives you an indirect idea whether or not the tumor you're dealing with has a high or a low neoantigen. And this is where I think that there's a slight issue with the theory that not every mutation would really cause a tumor to have a neoantigen, and they may have neoantigens, but may not necessarily be the neoantigen that is recognized by the immune system. So the neoantigen may not really induce an immune response, and also one size fits all of a TMB score of greater than or equal to 10 mutations per megabase may not really be ideal. So I do think it's still experimental. I think there have to be different cutoffs for different solid tumors, but since the FDA has given us blanket approvals, when you've got your back up against the wall, I would say you could use it as a biomarker, but I'd say tread very carefully. And this is the beauty about Nsclc. This is forever a changing field, right? This is emerging biomarkers. So Tarasa, we already have approvals for it. But look at this, you've got HER2 exon 20 insertions. I know we've got now approvals for that. But look at the NRG1 fusions, HER3, look at their incidence rate. You're increasing the cohort of patients that could be possibly molecularly matched with with therapy. So this is the beauty about lung cancer in particular. For the last 2 minutes, I'm going to very quickly take you through what I do in my clinic. So upfront, any new case that comes to us, NGS is my preferred platform of choice. There's no doubt about it. NGS with PD-L1. In the case where there's a recurrent or progression on disease at this point, I do like to do a molecular profiling. Tissue biopsy from the new metastatic site. If that's not possible, I would do a liquid biopsy. If one comes negative as a reflex, I would do the other. Sample choice, and I would go a little bit beyond the 10-12 genes because now I want to understand the tumor biology. If PD-L1 is not done, I would be doing a PD-L1 over here. Now, this was a case of a 50-year-old female Nsclc. We did the very typical sequential testing where we did the EGFR by PCR, we did ALK by IHC, ROS1 by IHC, and FISH, it came negative, and she refused to go for chemotherapy. So luckily we had some tissue left with us. So we went and did NGS, and she came back positive for a BRAF, and she started on a BRAF MEK inhibitor. So 12 days we got the report versus the sequential testing, which took approximately 3 weeks. Again, another case of a 79-year-old male non-smoker, was EGFR positive. They've started an aflibercept. He progressed. They did a rebiopsy. No mutation was detected. Old guy. It was in the peak of COVID. We were not very comfortable giving chemotherapy. At this point, we set it in for a liquid biopsy. We found a MET exon 14 skipping mutation, a VAF around 0.4%. And what happens over here is that when you increase the depth of coverage to around 15,000, 20,000 next, you're increasing the sensitivity and specificity to call out these small variants. And that's where liquid biopsy has a slight edge over tissue biopsy. And this actually helps us. Obviously, this is a case of tumor heterogeneity. That's why it was not even caught on tissue testing. And this patient was started on capmatinib. Now, my last case, and then I'm done for this, was an 81-year-old female with Nsclc. Tumor was insufficient. We sent her for a liquid biopsy. She came positive for a ROS1 mutation. She was put on crizotinib. She eventually progressed. She refused to do a tissue biopsy, so we again sent it in for a liquid biopsy. She had ROS1 was persistent, but she had acquired a ROS1 G2101A, which we know is a known crizotinib resistance mutation. So she was put on lorlatinib. This was short-lived. She again progressed, and liquid biopsy was repeated. Now, just watch the Keras mutations over here. Over here, we saw the ROS1 fusion was persistent. She had lost the ROS1 2101A, but gained a ROS1 2032R. And in addition to this, she had lost the Keras K117, and have now got the Keras 12B, which we know binimetinib is a targeted therapy, but you've got to be careful because this could be a potential CHIP mutation. CHIP mutations can be mistaken for being old, blood cells, especially in patients that were smokers, heavily pretreated. It can be they can be mistaken for being these discarded old WBCs. And CHIP is essentially clonal hematopoiesis of indeterminate potential. So if we see TP53, KRAS, JAK2 in our NGS reports, especially in Nsclc with a VAF less than 0.1%, go back, check with your service provider to ensure that it is that it is a CHIP or a true mutation. And this is my last slide. I think this is where we are. These are 50% of your Nsclc patients are going to fall within these biomarkers, which means that if you're using NGS, you can capture all this in one shot without having to go through sequential testing. And hopefully a larger cohort of your patients get molecularly matched to targeted therapy. And on that note, thank you very much for your patient listening.
Hello. Am I audible?
Yes, you are.
Thank you so much for this nice and beautiful presentation. So the session is open for discussion. Any questions? We can take one or two questions. Dr. Usma, you talked highly about the liquid biopsies. So what do you say? They basically detect heterogeneity among the tumor also. So they can detect few of the mutations which may not be present in the tissue tumor. So do you recommend doing both of them at the same time? This is one of the question. And another question is, if we do NGS on a tissue testing and we don't find any mutation in that, so we take it on face value, or should we repeat doing some ALK by IHC? Because few of our patients, they have shown IHC positivity by ALK, although they were negative by NGS. And one of my patients, similar thing happened with the ROS one also. So should we take it at face value, or what should we do?
Thank you for that question, both the questions. So I'll answer the first one about doing both together as liquid and tissue. If a patient can afford, absolutely. I think it's a brilliant idea, especially in metastatic stage 3B and above. I do think it's a good idea doing both of these tests together, tissue and liquid, just so that you get a clear understanding. Sometimes what happens is that there is a resistance mutation lurking in the background, and we're not even aware of it. So you could have an EGFR patient, and you could have a MET mutation or MET exon 14 just lurking behind at a 0.01%. So you're aware of it. You know that your patient's going to have a resistance, and you can maybe plan better and look after your patient in a more different way. So upfront, yes, but obviously everybody cannot afford it. So if you do tissue testing, and in tissue testing it comes back negative, I would then, as a reflex, do liquid test, liquid biopsy. To answer your question about the discordance between NGS and IHC, the two questions I would have. You're talking about ALK and ROS. ALK and ROS are best identified on RNA NGS because these are fusions. So while your IHC would say, yes, it's positive, we are seeing an expression, it can be that it got missed out on NGS because it was DNA NGS. You need to do RNA NGS. I find it very, I've come across one case only where IHC was positive and the NGS was negative, and that was because the DNA NGS was done and not a RNA NGS. And that could be the reason that there was a discordance between the two testing types. Now with ROS1, if it comes positive on IHC, as per the guidelines, you have to confirm it by FISH. A ROS1 cannot be taken as positive as on face value. It has to be done ROS1 on FISH. So this way or that way, I think that the key question is going back and checking with your service provider what type of NGS was done. And it can also be that, sorry?
So nowadays, whatever NGS we are doing, I think most of the service providers, and especially in Rajiv Gandhi, we are doing by both DNA and RNA.
That's correct. That's correct.
Most of the fusions, they are detected by RNA better, as you rightly said. So
Yeah.
One more question. So those patients who are having early stage Nsclc and they have been resected, so after resection, can NGS help us in determining the minimal residual disease as in myeloma, for example, or ALL, for example? So can we select few of our patients who will have benefit with the additional treatment in adjuvant setting? So can we have that?
There is data around it. There is testing around it. We do offer it, but I think you're one of the first clinicians who's actually asking me in lung cancer if they can do that. So I'm not seeing it upfront being done, but yes, the platform, the opportunity is available. So if needed, it can be done. I would recommend it, but then again, at the end of the day, as a treating clinician, it is your decision as to how you want to go forward. But I would recommend it. I don't see why not.
I think so. With the less of the tumor burden, I think it is more difficult to detect ctDNAs on.
That's right. I would do it on tissue. For this, I would do it on tissue. So with lung, I'm not comfortable doing liquid testing, ctDNA testing on anything less than stage 3B. I don't think any of us, any lab, anyone can proclaim and say what they want, but I don't think any of the labs have the sensitivity or the specificity for calling out anything less than stage 3B, because even gold standards like Guardant and Foundation will not accept a sample less than stage 3B, because everybody's validated it on that. So, and all the studies for concordance in lung with tissue has been stage 3B and above. So anything less than that, I would stick to tissue testing. And if tissue is not available, then well, we obviously can't do the testing.
Thank you, Dr. Ratna, for such a wonderful session. I think if there are no further questions, we will move to next session.
Thank you so much for having me. Thank you.
So, Dr. Aparna, hi. I'm Dr. Praveen. I have one question for you.
Hi.
Yeah, hi. So my question is, those like nowadays we are doing EGFR testing in early lung cancer. In like we try to do it on almost all the patients. So do you think that because recently I had one patient who was operated in AIMS. So AIMS people, they do not give the block to us, but the initial biopsy was done in my hospital. So can we perform EGFR mutation testing in the primary biopsy specimen also? Or, and is there any data whether the primary tumor versus metastatic tumor, not metastatic, the resection specimen? So is there a difference in the EGFR incidence rates and all?
To be very honest, I've not come across any data which shows a difference in the EGFR between at biopsy and after resection. So it would be very uninformed, uneducated of me to say there is a difference. But I don't see why it should be a problem that at biopsy, at diagnosis, or on that biopsy, you perform EGFR, why there should be a difference between that and the tissue testing at resection in early lung cancer. So I think it can be done on the primary that is with you.
Okay. And many a times we come across a situation where the patient is not willing for biopsies for the diagnosis, and sometimes the patient is medically in such a condition that you are not able to perform a biopsy, be it because of emphysema and repeated bronchoscopies, they have given negative results. So, and there are companies who are promoting liquid biopsies for the diagnosis also. So I do not know. So logically we can do it, but legally we cannot do it. This is my understanding. So what is your take on that?
I am not comfortable using liquid biopsy for diagnosis. I don't think liquid biopsy diagnosis can replace pathology. I don't think we're there at all. So I think when I'm not really sure who these companies are, but I would not be comfortable giving it to any of my patients or recommending it. It has to be validated. There's a lot of clinical work that goes in before we bring it into, a lot of research R&D work that goes in before we bring it into clinical practice. So I'm not comfortable till I've not seen data. And yeah.
And are there any researches going on in this aspect?
So the one that I'm very familiar with, because there are a couple, there's a lab I know in Pune that's working on using liquid biopsy as a base for calling out PD-L1 positivity. And that's what I mentioned, they use CTC, circulating tumor cells, irrespective of what stage of cancer the patient has. So that is the only area where I'm seeing some concrete work being done with CTC for PD-L1, for HER2, and I think for there's one more which I cannot remember. I think ERPR or something like that. But that's the only area that they're doing work that I'm familiar with. But anything over and above that, I'm not in India for sure.
Okay, thank you. Dr. Manish, are you here?
Yes, I am here. So we will proceed to our next session. So my screen is visible?
Yes, sir.
Okay. So I will be speaking about the various trials and the newer treatment options available as a targeted therapy in stage 4 Nsclc. After this talk by Dr. Arpana, so we have spoken about what are the different kind of molecular targets that are available and what are the newer targets. So we will be quickly running through all the different kind of targeted therapies available and what are the different kind of targeted we have been discussing. So these are the established biomarkers, EGFR, ALK, ROS, BRAF, which we have been discussing for quite some time now. And there are a few other newly available biomarkers, which are NTRK1, MET exon 14 mutation, RET fusions, and HER2 amplifications and mutations also. So what newer drugs are being used in these newly available biomarkers, we will be discussing about that. So this is not a one disease, this is a collection of many different kind of disease. Adenocarcinoma and squamous cell carcinoma, they were just two diseases earlier when the only histology was available, but now the adenocarcinoma and squamous cell carcinoma is basically the collection of various heterogeneous diseases in which the oncogene addiction is there. These are different kind of oncogenes which we have been discussing. So, whenever you have a diagnosis of CA lung, biopsy to establish diagnosis, and then biomarker testing. So at least testing for EGFR, ALK, ROS, we have been doing this for quite some time. Now we have extended doing testing for BRAF, NTRK1, RET, MET, exon 14 in all non-squamous NSCLC. So we're also doing a upfront evaluation of PD-L1 for all those patients who don't have these targeted biomarker testing positive results. So as of now, these are the various markers for which different kind of drugs are available for EGFR, ALK, ROS, BRAF, and NTRK positive mutations, and entrectinib and larotrectinib. April 2021, the first line option for MET exon 14, RET, and newer option for ALK and ROS, they became available. So we will be discussing a few of the case scenarios, and then we will be discussing the data about it. So this is a 56-year-old non-smoker gentleman. CT scan showing large left upper lobe mass with extensive metastatic lymphadenopathy with cervical lymph node biopsy revealing stage 4 adenocarcinoma and brain MRI showing 3 small lesions in frontal lobe, which are not symptomatic at the moment. So NGS biomarker showed EGFR deletion 19 mutation positive and negative for all other mutations, PD-L1 being 60%. So this is the phase 3 FLORA trial, and OS, it has definitely improved with osimertinib and advanced EGFR mutation in Nsclc, and this is the standard of care nowadays for stage 4 EGFR mutated lung cancer. You can see here that CNS progression is also quite low. CNS PFS is definitely statistically significant in those patients who received osimertinib. This is another case, similar patient, 56-year-old gentleman having ALK rearrangement. All other mutations, they are negative, and PD-L1 expression is 60%. So option here are crizotinib, the much initial option, which we used, then ceritinib approved in 2017, alectinib 2017, brigatinib, and now we have a front option of using lorlatinib or in sequence. So expanded approval for frontline setting in lorlatinib has been given in March 2021. So this is lorlatinib, which has got broad activity against ALK-resistant mutation. So the point is that if we use lorlatinib upfront in this setting, then the secondary ALK mutations, they tend to be low on disease progression, and hence it has got maximum PFS amongst all the ALK TKI at the moment. So secondary mutations in ALK kinase domain can induce resistance to first and second generation ALK TKI. These are all the mutations in which the crizotinib is active. So sequencing is one of the options, and using upfront lorlatinib is another option, which came from phase 3 CROWN trial, and it has shown superior PFS as compared to the standard of care crizotinib. But it comes with a unique toxicity, and lorlatinib is associated with hypercholesterolemia, hypertriglyceridemia, edema, increased weight, peripheral neuropathy, and cognitive effects. This is another case, similar 56-year-old gentleman having ROS1 rearrangement positive on next generation sequencing and PD-L1 expression being 60%. So this was the crizotinib first agent which was approved in ROS1 positive Nsclc from profile 1001, and this is the OS in ROS1 positive patients. Median OS achieved here by crizotinib was 51.4 months, and overall responses can be seen in this nice waterfall plot, which is close to 72%. Another drug, entrectinib, which has shown its efficacy in ROS1 positive Nsclc. Especially the good thing about entrectinib is the good amount of brain penetration which it achieves as compared to the crizotinib. And median PFS in all the patients we can see here is 15.7 a month, and those patients who had CNS disease, even in these patients, the median PFS was 11.8 months with this new molecular entrectinib in ROS1 positive Nsclc. So these are other few molecules which are active in ROS1 positive Nsclc. Lorlatinib is one of them, which can be used sequentially. You can see that intracranial overall response rates, they are highest with entrectinib. Median PFS is highest with lorlatinib in crizotinib naive patient. But efficacy in pre-treated patient is also present both in entrectinib and lorlatinib. Although at the present moment, the lorlatinib, the company is not giving patient assistance program if you're using lorlatinib in first line setting or second line setting after progression on crizotinib in ROS1 positive Nsclc. So these are different kind of side effects which come with these kind of drug which we use. Crizotinib, entrectinib, lorlatinib. I think the best one would be entrectinib. We are seeing the overall intracranial responses. Repotrectinib is still not available. So this is another case, and this patient had BRAF V600E mutation positive Nsclc, PD-L1 expression being 60% here. This is the frontline usage of dabrafenib and trametinib combination in BRAF V600E positive Nsclc. Total of 36 patients, they were analyzed, and you can see here that overall response rates for dabrafenib plus trametinib combination was close to 63%, and a few odd patients they will achieve complete responses, but most of the patients they have a partial response on this treatment. So this also comes with few other kind of toxicity, and most important toxicity with this is abnormal kind of fever that patient can have, and few of the patients, they can have very bad skin rash on being on this treatment. So these are the new therapeutic targets in Nsclc beyond EGFR, ALK, ROS, and BRAF. We will be discussing about NTRK, MET, exon 14 skipping mutations, and red gene fusions. To similar patient with NTRK fusion positive Nsclc, all other mutations being negative, and PDL1 expression is 60%. The brain MRI is still showing 3 small lesions in the frontal lobe. So NTRK rearrangements and TRK fusions in cancer, they are especially seen in those cancers which are rare. So commonly seen in those cancers which are rare, such as brain cancer, glioma, GPM, salivary gland tumors, very few lung cancer patients, secretory breast cancer patients. So here, and they are also seen in the thyroid cancers in children, the infantile fibrosarcoma, then congenital nephroma. So the NTRK rearrangements and TRK fusions, basically the normal role is in the neuronal development. It helps in the postnatal neuronal differentiation, survival, and function. But when the rearrangements in this gene is present, it leads to the overexpression and continuous activation of tyrosine kinase domain, leading to different kind of cancer. And these cancers, they are addictive to this gene. So larotrectinib is the drug here, which is treatment of choice at the moment. And the overall responses, you can very clearly see here in this waterfall plot, are to the tune of 79%. Median duration of response with entrectinib is 10 months. And if you talk about larotrectinib, the median duration of response is 35 months. So entrectinib has overall responses to the tune of 57%, larotrectinib 79%. Median duration of response almost 3 times in larotrectinib as compared to the entrectinib in these patients. So this trial involved all different kind of patients. It was a basket trial in which sarcomas, thyroid, Nsclc, CRC, they were all included. So if you see the intracranial overall response rate with pan-TRK inhibition, so the intracranial responses are to the tune of 54% in entrectinib. We can see on the right hand side the efficacy of this drug in the intracranial as well as the lung lesions, which we can see after 3 cycles of larotrectinib. Few of the side effects with this drug, they are peripheral edema, paresthesias, arthralgias, myalgias, weight gain, and muscular weakness. So NTRKs, they are very rare. Larotrectinib and entrectinib both show significant clinical activity. On November 26, 2018, larotrectinib was approved for NTRK gene fusions. This is another case, similar patient, 56-year-old, brain lesion 3, and MET exon 14 mutation, they were positive by NGS, PDL1 expression being 60%. So this MET has normal role in embryogenesis and wound healing, and skipping mutation in exon 14 causes inflamed deletion of juxtamembrane domain, leading to increased stability and constitutive kinase activation. This is profile 1001, crizotinib, initially used in MET exon 14 altered Nsclc. And the response rate, overall response rates were 32% with this drug. But there are few other drugs which have potent efficacy against MET exon 14 skipping mutation. So crizotinib is one of them, cabozantinib, savolitinib, tepotinib, and capmatinib. So if you see the IC50 concentration on which the drug acts, it is minimum for capmatinib, and we have the trial with capmatinib, then tepotinib, savolitinib, cabozantinib, and crizotinib. It is highest IC50 concentration. So even at very less amount, the capmatinib would inhibit MET14 altered Nsclcs. So recently approved selective MET inhibitors are tepotinib and capmatinib. Capmatinib is highly selective MET inhibitor. Similarly is the tepotinib. So this was the geometry mono 1 trial for capmatinib in MET exon 14 mutation positive Nsclc. The patients, they were treatment naive or pre-treated, and they would receive 400 milligram of twice daily capmatinib under fasting condition. These are the waterfall plot with this capmatinib in mutation positive Nsclc. These were the no previous treatment patient, and these were the previously treated patients. So 68% patient responded, and here 41% patient responded. Those patients who did not have previous treatment, the 68% patient would respond. So first line duration of response was 12.6 months. Second line duration of response was 9.7 months. Progression-free survival 12.4 months, and second line 5.4 months with capmatinib. This is another trial, Vision, tepotinib in MET exon 14 mutation. MET exon 14 skipping mutation was detected by tissue or liquid biopsy, and these patients received tepotinib 500 milligram every 21 days. So these are the waterfall plot with phase 2 Vision trial in tepotinib, and the overall response rates, they were quite high. So there were two cohorts. One cohort in which the biopsy was liquid biopsy, and another cohort was the tissue biopsy. So if you see the liquid biopsy and if you see the tissue biopsy, those patients who had tissue biopsy positive MET exon 14 mutation, they had better duration of response and better progression-free survival as compared to the liquid biopsy. So MET inhibitor, the side effect, peripheral edema, which is common, and then increased creatinine in few of the patients, but not grade 3 or 4 creatinine clearance increase. This is the summary. Crizotinib has high activity but poor CNS penetration. Next generation MET inhibitors are capmatinib and tepotinib, which are also active with improved penetration in CNS. This is another patient who had RET fusion positive Nsclc, similar 56-year-old gentleman, non-smoker, with KIF5B RET fusion positive Nsclc, PD-L1 being 60%. So the RET multikinase inhibition, these are the drugs which inhibit RET: cabozantinib, vendatinib, selpercatinib, and prasitinib. But you see the highest IC50 concentration is with cabozantinib and least with prasitinib and selpercatinib. And overall responses, they are highest with these two drugs, LOXO-292 and VLU-667, to the tune of 68% and 58%. Cabozantinib and vendatinib also inhibit RET, but they have plenty of off-target effect as well. So the drug of choice, they are selpercatinib and prasitinib. So these are the two drugs which are approved for this RET inhibition. These are the Libretto trial with selpercatinib, and this is the phase 2 Arrow trial with prasitinib for REST fusion positive Nsclc. And in both of these trials, the PFS was to the tune of 16.5 months in selpercatinib trial and 11.3 months in prasitinib trial. So all these newer generation RET inhibitors, they are active in brain. This is very, very important. And overall response rate, we can see, are to the tune of 91% for selpercatinib and 56% for prasitinib in these clinical trials. So May 2020, the FDA approved selpercatinib for the treatment of RET fusion positive Nsclc, and prasitinib was then FDA approved in September 4, 2020. So this is the current treatment paradigm for molecular biomarker positive advanced Nsclc. This was our first slide. And 35% of the patients with advanced Nsclc having driver mutation by FDA approved agent. So this is how it goes today. So what about those patients who receive first-line checkpoint inhibitors in metastatic Nsclc with high PD-L1 expression and driver mutation? So all our previously discussed patients, they had PD-L1 expression of 60% with some kind of addictive driver mutation for them. So this is some trial data which you can see here that there is lack of efficacy with immune checkpoint inhibition in EGFR mutation positive Nsclc. So phase 2 study for pembrolizumab with PD-L1 expression positive EGFR mutation positive Nsclc, it was stopped for futility because it did not work in these addictive patients. there is potential toxicity also with sequential use of immunotherapy followed by oral TK. So if you use immunotherapy followed by osimertinib within 3 months of immune checkpoint inhibitor, 24% of the patients will have some kind of severe immune response phenomena, and very many patients, they can have grade 3 pneumonitis or grade 3 colitis and grade 4 hepatitis on sequentially using immune checkpoint blockade followed by osimertinib or osimertinib followed by immune checkpoint blockade. So talking about HER2 positive patients, HER2 overexpression can be seen, HER2 amplifications and HER2 mutation, and these are the targetable biomarkers which we have at the moment. So this is positinib. This is second line therapy in advanced HER2 exon 20 insertion positive Nsclc. Phase 2 Zenith 20 trial with positinib in advanced EGFR HER2 exon 20 mutation positive patient, it showed a significant advantage. So positinib for HER2 exon 20 insertion positive Nsclcs. Trastuzumab emtansine TDM1 in mutated HER2 mutated lung cancer. You can see here that overall responses are to the tune of 44% and PFS is to the tune of 5 months with TDM1. This is another Destiny Lung 1 trial for trastuzumab deruxtecan for those patients given in the two cohorts, one HER2 overexpressing and other HER2 mutated. And you can see here that primary endpoint were overall response and secondary endpoints were PFS and overall survival. If you see here, overall responses were to the tune of 61%. The disease control rate was to the tune of 90%, and median PFS was around 14 months in this Destiny Lung clinical trial. For the mutated patients, for overexpression patient, the PFS was 5.4% and median OS was 11.3%. So HER2 mutated patients, they respond better to trastuzumab deruxtecan. But TDM1 and TDXT, it comes with toxicity also. The most important toxicity in which we are afraid of is interstitial lung disease, and few of the patients, they can have very immune suppression and leading to decreased TLC and febrile neutropenia and deaths also. So these are the toxicities. Those in dark blue, they are grade 3 toxicity. So febrile neutropenia, grade 3 neutropenia, they are very common. We have to be very cautious about it once we are using this treatment. Targeting HER2 in Nsclc, so we have already discussed. Keras, this is the last topic which I'm going to discuss, and Keras mutations, they are common. It has been very challenging till now targeting Keras mutations, but now we have a drug, sotorasib, CodeBreak 100 trial, and these were the patients who had locally advanced or metastatic Nsclc, and they had progressive disease on previous standard treatment. So they were given sotorasib 960 milligram. If you see here, the median age was 63, and most of the patients, they were smoker. So 90% of the patients, they had smoker, and almost all the patients, they had received immunotherapy also and chemotherapy also. So 90% patients, they had received PD-L1 checkpoint inhibitor before getting this drug in the clinical trial. You see the overall response rates, they were to the tune of 37%, and disease control rate was to the tune of 80.6%. This is the depth of response. And the durability of response, the median duration of response was to the tune of 10 months, and disease control rate was 80.6%. So till now, the targeting Keras was extremely difficult, and now we have a drug for this also. So with this, I think I have covered many of the mutations in lung cancer, which we have not been doing for last so many years. With this, I would stop, and the topic is open for discussion.
Hi, Manish. So it was a wonderful, elaborative session taken by you. And you have covered almost all the molecular aberrations and their targeted therapy. I would like to ask one question, Mani. Uh, the same question you asked Dr. Aparna also. So, what is your clinical practice if your patient is having all the finances? So, do you really proceed with liquid-based plus biopsy-based, both the NGS, or you prefer one of the two?
So I have been doing tissue NGS at the moment. It becomes extremely problematic for patient and doctor to send both of the sample and then track both of them. But I think it makes sense if you have all the finances. You can see the tumor heterogeneity. You can definitely look at the mechanism of resistance a patient tumor can have. I think it makes some sense. Are you doing that?
No, the practice, my practice is I always prefer FFP, and if tissue is not there, then I try to do it on the liquid biopsy. And have you ever done NGS liquid biopsy based NGS on any other tissue, like apart from blood, like in CSF or urine or pleural fluid? Have you ever tried that?
No.
So is Dr. Aparna here?
I'm here.
Yeah, hi, Dr. Aparna. Again, I'm asking the question only.
No worries.
So in RGCI, we used to do EGFR mutation testing on other samples also, like CSF we have performed, then pleural fluid we have done, then ascitic fluid also we have done. But I'm not sure of the validation for that, and I'm not sure of whether other tissues, other fluids can be used for NGS-based platforms or not.
So they can be used. So I know when we talk about liquid biopsy in all these conferences, we go on talking about NGS blood, but actually liquid biopsy can also be done on CSF. It can be done on, a plethora of different sample types. And I know in RGCI, Dr. Moshmi and team have done a fantastic job in validating it on CSF. So from the technicality perspective, I don't see it as a problem as long as it's validated. I think it's got a good sensitivity. I know a couple of my patients have actually come to RGCI and had it done where, have had themselves tested at Dr. With Dr. Moshmi. So I think I don't see a problem with it. As long as the validations are in place, there has been concordance or some sort of a thing established and liquid, irrespective of the liquid sample type, I think it's a good alternative, especially in this early, early lung cancers, where where the ctDNA count may be low. I think we can use it.
Okay, thank you. And is the amount of sample also a challenge, like in CSF? So we might get only 0.5 or 1 ml or 2 ml as a sample. So is it adequate usually for doing or to extract the DNA out of it?
So logically, yes, but then again, it depends from lab to lab as to what is their protocol for DNA extraction. Every lab is different. So while your lab may say, RGCI may say 2 mils is enough, my lab may say 1 mil is enough.
Okay.
So it varies from lab to lab and how it's been, and how it's been validated.
Okay. Thank you, Dr. Aparna.
So, Dr. Praveen, we had a patient of CA lung who presented in very bad shape in ICU and with meningeal disease actually. So we were not able to perform a solid biopsy for that patient, and somehow because of the meningism, we did a CSF study on that patient, and then we did a NGS, and unfortunately that NGS came out to be positive. We started that patient on osimertinib. But I think we lost that patient, did not work well for that patient. So I think there are few of the clinical reports that say that we can do these kind of testing in other fluids as well. I think Dr. Lars has been doing this in pleural fusion also, I think, no?
Yeah. So we have seen in all sort of samples. In CSF also we got, in fact, if logically, if you speak about the CSF, then you tend to see the heterogeneity in the resistance mechanism also. Like many a times what you have seen is that your T790M presence after treatment, it happens only in the extracranial site on many occasions, and intracranially it is still sensitive to your first or second generation TKI. They do not have T790M. I think Dr. Aparna, you can elaborate on the same thing if you have any experience regarding the same.
No, that's very true. We have seen CSF as and again, I've had it tested at RGCI. We've not done it in any of the labs that I've been associated with, but it does a fantastic job. It does exactly what liquid biopsy is supposed to do, irrespective of the sample, blood or CSF or pleural fusion, and it helps call out those clonal. It helps call out tumor heterogeneity. We're able to track those resistance mutations. So all those options are there, and I think it's a brilliant sample type to use. The only thing is CSF sometimes is a little invasive and can be a little difficult extracting that. So blood would be an easier alternative, but if blood's an issue, CSF, I think, excellent results, and especially in calling out the C790M and the C797S, it's really, really good. It boils down to the lab. I think at the end of the day, it's the lab, their practice, their validation, their protocols. If your lab is good and it has the right technical team, then doing all this stuff is, I'm not going to say it's child's play, but they definitely have the elegance in performing this testing, which obviously benefits us, our patients in a clinical setup.
Okay. And so, Dr. Aparna, one more practical question. So, see, I have shifted from RGCI to Akash Healthcare, and we have that challenge that we do not have any molecular lab with us. So, like if we are doing a CSF analysis or if we are doing a pleural fluid analysis and we want to perform some molecular liquid-based assays on that, so is there any specific technique we have to follow, like for cell block, sometimes you need to take the fluid in the formalin only, and then you have to send the fluid immediately, because if you are taking it in formalin, I think the fixation happens over there only. But if you are not taking the fluid in the formalin, then issues are there. So can you just if
Sure. So it depends on the tube in which you collect the sample. So we have like how when we take a blood sample, we put an EDTA, those purple top tubes. It helps preserve the DNA when we're doing germline testing. The other option that we have when we're doing ctDNA, we use Streck tubes. These Streck tubes have a solution which helps in enumerating and preserving the ctDNA. So it's either from PaxGene or it just increases the stability of the sample. So by the time you take the sample in your lab, in your hospital, and you call your service provider, whichever lab it is, it helps maintain the stability. And as long as you keep it in minus 80 degrees, it's I don't see it as a problem. So it's kept at minus 80. During transportation, you maintain those temperatures, not minus 80, at least a minus 4. Maintain those temperatures and have it delivered to the lab. We've not seen issues. We get samples from pan-India, international. As long as temperature is maintained, shouldn't be an issue, especially if you don't have a molecular setup in your organization.
So Dr. Aparna, do you do only EGFR on these kind of sample, or whole of the multi-gene multiplexing can be done on these?
We're doing multi-gene, but then again, I am not doing it on CSF. I think in India today, only RGCI has that ability, has the capability and the ability for it. But we do it for multi-gene. So you have it as standalone, just EGFR. Then you can do just a very typical lung cancer panel. Then you can go beyond the lung cancer 12 gene and look at far many more genes. So we're doing it all now.
So I think Dr. Praveen, we are getting late for the next session. Dr. Babu is here. Thank you, Dr. Aparna. Thank you, Dr. Praveen, for this wonderful and nice discussion. So I would like to invite our next speaker for today, and he is Dr. Venkatpati Babu. He is a senior consultant at Assam Cancer Institute. He will be speaking about early stage Nsclc. Dr. Pradeep, good evening.
Good evening, Dr. Manish. Thank you for inviting for the presentation. So there are excellent discussions that are going on. So many enlightenments regarding the liquid biopsies and liquid. So today, my talk is regarding the osimertinib. We know that this is our favorite molecule whenever we find a EGFR mutation in advanced lung cancer patient. But let us see and revise why we are still using it after so many years after its approval. Osimertinib still stands as the standard of care in advanced EGFR Nsclc. So when we see the Globocon data among the first 5 cancers, lung cancer stands at the highest incidence, both in terms of occurrence as well as the mortality, followed by breast, colorectal, prostate, and stomach. And lung cancer, when we see the mortality also, it causes deaths in more number of patients than it causes in a specified time frame, which means it causes more deaths than the incidence. In both sexes combined, when we see here, 11.6% of all the cases, they are lung cancer, and 18.4% of all the cancer deaths, they are due to the lung cancer. And we know that the cause of lung cancer, many of the causes of the various cancers are not known, but in lung cancer, the majority of causes, majority of the cases, they occur due to the smoking. They occur due to the smoking. And after 5 decades of knowing the cause, we still are fighting with the most common cause of the most common cancer causing, and which is the leading cause of death. The question is, why should we use the best drug that will maximize the benefit of EGFR mutation patients? Why should we use the best drug first? Why don't we use in the second line? Let us see the various first-line options that are available in EGFR mutant Nsclc. We have 3 generations of EGFR mutants, EGFR TKs that can act against the EGFR mutant Nsclc. The first generation, erlotinib. The second generation is decamatinib. The third generation is the osimertinib. When we see the third generation osimertinib at the first line, the Nccn as of 2022, as of today, recommends osimertinib be the most preferred EGFR TKI in advanced Nsclc. May I request my senior colleagues and my colleagues to keep the mic on mute. So EGFR mutation, if it is discovered prior to the first-line systemic therapy, osimertinib is the most preferred drug. And of course, the first line and second generation TKs can still be used like erlotinib, afatinib, geftinib, and decamatinib. However, we know that in many of the places, EGFR mutation is not so easily can be done, and it takes some time. So when it is discovered during the after the initiation of first-line systemic therapy in the form of chemotherapy, we can complete the options are to complete the planned number of systemic therapy cycles, chemotherapy cycles, followed by EGFR mutation, EGFR TK as the maintenance therapy, or we can even interrupt the systemic therapy and can start on the EGFR TKI. So both are options available and both are practiced nowadays. So when we see the difference between first, second, and third generation TKIs, the inhibition activity differs between the 3 generations, among which the first generation EGFR TKIs, they are reversible in action and they do not form the covalent bond at the ATP binding site. So it is reversible type of binding in the first generation, whereas in the second and third, it is irreversible type of binding. And these TKIs, they cause the covalent modification at the ATP binding site of the EGFR, resulting in this irreversibility. And when we see the ability to cross the blood-brain barrier, which is the most important feature we look at, but when we are treating the cancers like a lung cancer, which has high prediction for the CNS metastasis, the first and second generation TKIs, they have the minimal penetration into the brain. And among the first generation, we know that erlotinib has a little bit more penetration into CNS compared to the geftinib. And coming to the second generation, the CNS activity is not exactly characterized, but we know that there is some activity but it is minimal. Coming to the osimertinib, we know that there is a significant ability of the osimertinib, the third generation TKI, to cross the blood-brain barrier, and so it has the intracranial activity against the brain metastasis also. What is the main difference? The main difference is in the structure as well as which is resulting in their chemical activity also. The first and second generation, geftinib, erlotinib, they are mainly anilinoquinazolines, whereas second generation is derivative of this anilinoquinazolin, and osimertinib is the monoanilinopyrimidine. The structure as well as the activity of osimertinib is significantly different, and its binding, so as the binding with the ATP binding site. So osimertinib, from the previous slide, we know that is a third generation irreversible CNS active EGFR TKI, which can inhibit both EGFR sensitizing, EGFR T790M mutations, as well as the wild type of EGFR TKI. However, we know that the inhibition of wild type of EGFR is relatively less with osimertinib, and so the rash, which is the class side effect of the EGFR TKI, is very, very less with osimertinib. The main activity of osimertinib is against the two most common mutations of EGFR, that is exon 19 deletion and exon 21 L858R mutation. So it also inhibits inhibition of T790M when it is found in the baseline as well as in the second line, and it has very, very lower activity against the wild type of EGFR. And we do see that in the both preclinical activities and human trials also, it has significant intracranial activity. So as an oncologist, we do depend upon the data that has our most important endpoint that we look at in many of the clinical trial is overall survival. And the standard trial that has formed the basis for the osimertinib to come into the clinical practice is the FLORA trial. It is a randomized double-blind phase 3 study which has assessed the safety and efficacy of osimertinib versus the standard of care EGFR TKI, that is first generation TKI, in both locally advanced as well as metastatic advanced Nsclc. This is the FLORA study design. We know that the key inclusion criteria are the adult patients with a performance status of 0 and 1. Looking at the trial retrospectively, this looks like a little bit setback because obviously clinical trials adapt a strategy to include the best of the patients so that the clinical trial will be successful. But we do know that EGFR TKI can be given in ECOG performance status 3 or 4 also, and they do improve a lot. But in this trial, we can see that the population include the performance status 0 or 1 only, and two important mutations which we have discussed were included, and there should be no prior exposure to any sort of TKI, and stable CNS metastasis are allowed. So patients with brain metastasis are not included, which is actually a very important point for this study. And osimertinib is started at 80 milligrams per day, and against both geftinib and erlotinib at the prescribed doses. So these patients, they were assessed every 6 weeks to see the responses till there is a progressive disease. One of the significant point is that crossover is allowed whenever there is a progressive disease on the first generation TKI, which is assessed by the independent review committee, and they are allowed to take osimertinib when they have T790M mutation upon progression. So the primary endpoint is PFS, and the secondary endpoint is overall survival, and the other factors like objective response rate and duration of response, and obviously the safety. When we see the osimertinib, which is the primary endpoint, that is PFS, the median PFS is 18.9 months with osimertinib versus 10.2 months the standard of care. And we know that in majority of the clinical trials that are taking place nowadays, PFS is the direct measure. In fact, Others variants of PFS, like radiological PFS, are being considered in many of the trials. But PFS and OS are the two important parameters. And majority of trials, it is seen that PFS is converted into overall survival, although it is not a compulsory phenomena. Flora was powered mainly to see the PFS difference, and so it is the primary endpoint. When we see this forest plot, the PFS benefit is seen across all the subgroups for all the sex, for all the races, whether patient is smoker or not, whether the patient has brain mets or not, and all the performance status of 0 and 1, and all the types of exon mutations of the EGF for both 19 and 21. One of the important points that is relevant to today's discussion is that whenever EGFR mutation is found by ctDNA, is also the overall the PFS benefit has been seen in those patients also. When we see the overall survival in the final analysis, we can see here the median OS is 38.6 months with osimertinib versus 31.8 with the EGFR TKI, and we should keep in mind that many of these patients have received osimertinib after progression. The hazard ratio is 0.79, which means that nearly 21% of the patients, their events have prevented from the death by using the osimertinib. So median overall survival is greater than 3 years, whereas in the first generation it is less than 3 years. And osimertinib patients, they are more likely to alive at the second year point and third year point at 24 and 36 months respectively. So 28% of patients, they are still receiving osimertinib at 3 years. And we know that 22% of the patients were on treatment at the time of data analysis and data cutoff. And time to first subsequent treatment, this is the one of the most important point which we need to keep in mind while deciding whether we need to use osimertinib in the first line versus second line. Because osimertinib, we know that median time to subsequent treatment is 25 months, whereas for the rest of the comparator arm, that is the first line, it is only 13 months, which means they might have received as a chemo or the subsequent TKI after that. So osimertinib, whenever the Flora detail, the results were declared, it has set an unprecedented landmark in terms of PFS in EGFR mutated Nsclc. We know that there is a gradual improvement from the first generation to third generation. However, in terms of safety, efficacy, and in terms of the benefit, overall benefit, you can see that osimertinib stands apart from the 9.5 months with the geftinib to 18.9 months with the osimertinib. We shall discuss the afatinib and decametinib in detail in the coming slides, whether although they are much efficacious than the first line, their role is relatively less compared to the osimertinib as well as the first generation drugs. So coming to the OS curve, we can see here that in the Asian patients and in patients who are particularly in these Asian patients, it is crossing the line of unity, which means the benefit in these particular patients is doubtful. But we do know that whenever we are using in the patients, particularly in elderly patients and even with the patients with a poor performance status, osimertinib definitely benefits, and the definitely is palpably visible in those patients who are otherwise ineligible for chemotherapy. So PFS benefit is consistently maintained across all the subgroups, and OS benefit is in favor of osimertinib in majority of the subgroups. So this is the outcomes of Indian patients with the first generation TKI from the various real life studies, from the AIMS, Tata TMH, and ADR. We can see here it varies anywhere from the 6 to 12 months, and some studies although has shown that it is 18 months. The real life, majority of the real life stories, the clinical trials, they show that the benefit is nearly 1 year, across the 1 year. So when we compare the second generation versus third generation, why we should prefer third generation compared to the second generation? So the trial itself has garnered some of the criticism, the documented the final analysis. But when we see the inclusion criteria, it is the comparator included geftinib alone, and erlotinib is not there. And it has started at 45 milligram per day decametinib. And there was a racial analysis also, Japanese versus Chinese versus other East Asians and non-Asians. whether there is a separate benefit or whether there is a differential benefit. So the primary endpoint is PFS, just like osimertinib trial, and secondary endpoint is OS. In the FLARA, we have seen the details. Let us see the Archer exclusion criteria. One of the key lag point against the Archer trial is that it has excluded any brain or leptomeningeal metastasis. And in fact, any patient with interstitial lung disease or even non-infectious pneumonitis were completely excluded from the trial. And while osimertinib trial has recruited patients with CNS metastasis. When you see here, so this is the, whenever we analyze the Kaplan-Meier curves, what we look at is the separation of curves, how good it is, how early it is, and how wide it is. But here we can see in the Archer trial that for the first 6 months, the geftinib and the decomatinib arms are actually hugging each other and then only getting separated, which means that if any patient, if he progresses within the first 6 months, is no different from the patient using geftinib. But here we can see here in osimertinib trial that the curves are separated immediately from the very beginning in the first 3 months, and then the distance and the separation is maintained. And when we see the hazard ratio, it is 0.59 and it is 0.46. We keeping in mind that we actually cannot compare trial to one trial to another. The cross trial comparison may not yield the exact reports, but we do know that on the comparator arms, it is the first generation TKIs. The trial population may slightly vary, and definitely they are heterogeneous. But keeping all these points in mind, we still do know that these first 6 months are really important in a patient with metastatic Nsclc. One of the most important criticism for Archer trial is that it is a hierarchical analysis of the overall response rate followed by overall survival, which means that whenever if the overall response rate is statistically significantly different between the compared to arms, only then OS can be significant. Here in the Archer trial, the overall response rates of 72 versus 75% between the first and second generation TKIs are really not statistically significant. And so the OS benefit that is being reflected here may not be actually analyzed in as a real benefit. So that is the criticism that is garnered against the decomatinib trial. So till the more prospective real life studies show the actual result, we cannot actually say that decomatinib has so much of benefit. But as of now, when we discuss the OS benefit, it is the osimertinib trial among the TKIs and chemo plus geftinib plus chemotherapy from the TMH trial. So this has mentioned in the Canadian consensus also, because the trial had a hierarchical stratified statistical design, and it did not meet the significance in terms of overall response rate, and so a p-value could not be given to the overall survival to the decomatinib. So here we have discussed almost all important points about the hierarchical gatekeeping procedure for the statistical analysis, etc. Let us see the serious adverse events in the decomatinib versus osimertinib. Dose reduction were needed in nearly 2/3 of population, that is 66%, whereas in the osimertinib, dose reduction is needed only in 3%, which is slightly equal to or less than the first generation TKI. Serious adverse events, that is grade 3, grade 4 side effects, are seen in 27%, whereas the adverse effects with osimertinib are only 4%. And coming to the death, adverse effects, all the side effects that are leading to death is nearly 10%, whether it is 2% with the osimertinib, which are really these points, the safety endpoints are the ones we actually need to look at while selecting the TKI. Coming to the other second generation that is afatinib, we can see here up to 12 months, afatinib at the end of the analysis, which has failed to improve the OS versus geftinib in the Lux-Lung 7 trial. So again, keeping in the mind that this is a cross-trial comparison, we can see here in the afatinib trial, stable brain mets were included, but there is no OS benefit in the trial, and up to 12 months, this the curves do not get separated, and so we actually cannot say that afatinib is much better than geftinib. In the same way, up to 6 months, the curves are hugging each other for the decomatinib, And osimertinib, we have seen this, the early suppression of the curves. And one of the important point we do consider in patients already having brain metastasis or who are at risk of brain metastasis due to the heavy burden of the disease in the systemic disease below the brain is the intracranial response of the TKI, which we are actually selecting. So when we see the isolated CNS progression, it is better with the third generation compared to any previous generations. So first and second generation, they have very poor distribution in the brain as well as CSF. And third generation, it has a clear intracranial permeability. So in FLORA trial, both systemic and intracranial efficacy were analyzed, and it is shown that osimertinib definitely have a better intracranial penetrance and efficacy. So not only in the preclinical studies, in the clinical trial, that in the FLORA, we have seen that patients with the CNS metastasis and so with the treated CNS metastasis, osimertinib, the PFS is 15 months, whereas compared to gemcitabine is 9 months. In treated CNS metastasis, the overall survival is also better with the osimertinib compared to the gemcitabine. We can see here a good hazard ratio of 0.48, which means that the 52% of intracranial events are being prevented by using osimertinib compared to the gemcitabine, which is really significant that half of the patients, they do not have intracranial progression when we use osimertinib compared to gemcitabine. So these are the graphical representation of the benefit which we have discussed in the previous slide. That is the reason why osimertinib is included as the preferred EGFR TKI in advanced stage disease in Nccn as well as in EMA as well as by DCGI. And tolerability profiles we have seen compared the osimertinib with the dacomatinib. And when we see with the EGFR TKI of the first generation, which is really well tolerated in many of the trials. So osimertinib has lesser grade 3 events compared to the first generation TKI. And any EAE adverse effect leading to discontinuation is 41% in the osimertinib, whereas it is 50% in the gemcitabine. We can see here, and we also know from the practical experience, it is a very easy and tolerable drug, except for a very few patients who might have QT prolongation and other side effects, who account for less than 5%, hopefully. And we can see here in the FLORA, it is less than 1% of paronychia, dry skin, stomatitis, whereas it is 30%, 37%, 22% in the comparator arm. One of the important side effect is the diarrhea. However, it is almost equal and as much as with the first generation TKI, but it is easily manageable. So coming to the safety data of Archer and FLORA, which we have already seen, those reductions are really significant in dacomatinib, even compared to first generation as well as the third generation. And we know that lung cancer is a geriatric disease in majority of the settings. So dacomatinib, how it performed in the geriatric use, compared to the young patients, they have higher incidence of grade 3 or 4 adverse reaction, that is 67%. There are more frequent dose interruptions because of polypharmacy and because of the poor tolerance, and there were more frequent discontinuations and dose interruptions. So why we should consider osimertinib as the first line rather than in the second line? The reasons are many. One of the most important reason is that whenever a patient is affordable and when we have access to the osimertinib, why should we prefer in the first line? This is the same reason as that whenever we have a connecting flights, there is always a probability that we will miss the connecting flight. But when we have a single flight that is reaching at the destination of what we want, so why not catch the direct flight and take the connecting flight? The reasons are as below, because when we use the first generation TKI or second generation TKI here, so many of the patients, they do miss the flight because of the poor performance status. So we can see here nearly 1/3 of patients, they do not receive second line therapy at all. And 1/3 of patients, they do not have T790M mutations, bearing which we cannot actually give osimertinib. Some of them might have histological transformation as well. we may not know because of when we don't do the biopsy. So approximately, we are passing on the benefit, saying that for this, quoting the 2 months of extra PFS when we used in the second line, by combining first 10 months versus second 10 months, only 1/3 of patients will ultimately be using the osimertinib. So weighted average PFS is 15 months with the standard of care TKI in first line followed by no therapy, with chemotherapy in 1/3 of the patients and osimertinib in 1/3 of the patients. So 33% of patients only ultimately will receive osimertinib in the TKI whenever we are planning it as a second line rather than the first line. So this is the approximation of how many patients may not be eligible for the next generation TKI. So one of the study that is quoted that osimertinib, why we should prefer the osimertinib in the second line but not in the first line, is the geotag study, which has shown that using afatinib in the first line followed by osimertinib may be more better than using osimertinib in the first line. So let us see what are the backlogs of the geotag study. It is a retrospective study, and patients, majority of the patients who actually matter while we are doing a prospective study were excluded from this study in the form of those who are T790M baseline were excluded, and patients who died on the first line afatinib were not included in the analysis, and those who could not receive the second line therapy has been excluded from the analysis, which actually have a potential potential to influence the analysis and so the outcomes. And most of the patients, they have higher incidence of del19. We know that del19 patients do better than the exon 21 mutations. And so they have initiated osimertinib greater than 10 months before the enrollment. And so the overall duration of the osimertinib, the duration is really, really less. So we cannot put geotag, or we cannot actually consider geotag as the the real evidence when we are considering osimertinib to decide between the first line versus second line. These are the reasons which we have discussed, that we may not know who will develop EGFR T790M mutations, and not everyone will be fit enough in the second line to receive the cell line. So coming to the summary, osimertinib demonstrated a clinically and statistically significant improvement in overall survival. The median OS benefit of greater than 3 years. It is a new benchmark of osimertinib, which may be met or crossed only by osimertinib plus chemo trial, which FLAWA2 trial which is still going on. FLAWA is the first time an EGFR TKI PFS is directly converted into OS. Nearly 30% of patients still remained on osimertinib for 3 years, and all the patient subgroups, they have consistent benefit in terms of PFS, and majority of the subgroups have OS benefit. So safety profile, we have seen that it is really appreciable in terms of good tolerance, both for the patient as well as the physician. I thank you for this opportunity, and I end my talk.
Thank you, Dr. Pradeep, for this wonderful presentation. So I think we are already getting late. In the interest of time, we can allow one or two questions, if any. Otherwise, we'll have Dr. Pradeep you in the panel discussion as well. So you are seeing plenty of lung cancer patients in Assam Cancer Institute, I think. So have you changed your strategy? Because few of the patients, they're not that well-to-do that they can afford osimertinib. Do you try to sequence your patients, or you still say osimertinib for all of them, or you selectively use osimertinib in exon 19 and give L858R another chance of some ramucirumab or any other drug, or dacomitinib?
Yeah, thank you, Dr. Manish. The challenges that I face here in Assam is quite different from those in Delhi and RGCI. If the patient is not affordable for osimertinib in the first line, they are not affordable in the second line also. So in all those patients who are affordable for the osimertinib, definitely it is my first line choice. There is no second thought about that. But in those patients who are not affordable for the osimertinib, I use the poor man's osimertinib, that is Gefnib plus chemotherapy. So
you are doing Gefnib plus chemotherapy. So I have heard about this combination very long time after. So I have not heard about this combination in near time. So Pemetrexed and Gefitinib are you giving? For how long you are giving?
Sorry.
For how long you are giving that combination?
So I have given this combination while I was in Visakhapatnam also, Vizag TMS, and then I am continuing here. So currently I am using this combination in two women who are greater than 60 years, and the tolerance is quite good. So going on.
So you don't find plenty of toxicity with that combination?
Yeah.
Okay, thank you so much. So I quickly invite my next speaker. He's Dr. Praveen Jain, and he's senior consultant and HOD Akash Healthcare Institute, Dwarka. So he will be taking us through the panel discussion. I invite Dr. Praveen.
Thank you, Dr. Manish. Thank you for the introduction. Surbhi, I think you need to stop sharing so that I can share the screen. Thank you. So over a period of the duration of last 1.5 hours, so we have gone through the molecular landscape of lung cancer. We have seen different targeted therapies, different targets, and now Venkat has taken us through the journey of osimertinib in advanced non-small cell lung cancer. So my job here is very limited data regarding the early stage lung cancer patient, but these are those important patients where if we treat early, so the outcome of the patient can improve to a larger extent. So we will discuss it. It's going to be a case-based discussion. I would like to call upon my panelists. So Dr. Venkat Pradeep Babu,
Sir,
you are
here.
here. So and then after that, Dr. Manish Sharma, you are also here.
Yes, I am here.
Okay. Dr. Abhishek Yadav. Dr. Abhishek, is he here?
So I saw he had joined. I think there must be some issue with his.
Yes, sir, he is here.
Dr.
Okay.
Rajat is here.
Dr. Rajat.
Yes, sir, I'm there. Dr. Abhishek is just coming back. He has gone with his dog for a walk.
Okay. Dr. Srijana.
Yeah, Dr. Srijana is here. Yes.
And Dr. Priyanshu.
Hi, sir, I'm here.
Hi. So
I think
now,
that after that IS couple has left, so Dr. Abhishek has occupied that Chagraj Stadium, I think.
so we have attendance of almost 100%. Abhishek is missing, but he will join in between. So let us.
Sir, I have joined. Am I audible?
Yeah, you are audible. So even if you are on a walk, then also you are audible on system. So here is my case. So it's a hypothetical case. This case doesn't belong to me or anybody else. So 67-year-old gentleman, non-smoker, presented with mild cough. Chest X-ray showed a very small lesion in the left upper lobe. CT chest showed lesion in the left apical lobe. So these are the CT scans and the PET CT scan of the patient. We can see here a lesion. So it looks like a solitary pulmonary nodule only. So the PET CT scan shows FDG avid lesion in the left upper lobe, and there was a pleural tag also, and this was the report. So intensely FDG avid well-defined lobulated soft tissue nodular lesion in apico-posterior segment of left upper lobe with adjacent pleural tag. Non-FDG avid subcentimetric prevascular lymph node, likely non-specific reactive nodes. And we have come across these kind of reports where the lymph nodes, they are non-reactive. So we will discuss about it. So the biopsy from the primary lesion turns out to be adenocarcinoma of the lung. So now what next? So I think we will start with Abhishek only because he was the last to join. So Abhishek, what is going to be your workup? So we have discussed this on many occasions. So Can you just elaborate on the workup?
Sir, sorry, there was a phone call in between, and I feel there's just a solitary pulmonary nodule, nothing else.
Yeah. So we have already done a PET CT scan. We have done a CT scan of the chest, and we have done the biopsy. So apart from that, do you need any further imaging test?
Till now, a CT chest has been done, nothing else.
CT chest, PET CT scan, even the biopsy has been done from the primary lesion.
Okay. And sir, what are the PET CT shows? There is nothing else except this thing.
No. There is a FDG avid left upper lobe lesion along with pleural tag and the non-FDG avid subcentimetric prevascular lymph node is there, which seems to be non-specific.
What about the pleural thing? Sorry, I missed.
So there was a pleural tag along with the nodular lesion.
Okay.
So it's a contiguous one.
It's a contiguous one. Sir, I would like what has been the biopsy report?
Adenocarcinoma.
Adenocarcinoma.
So the question here is that do you do MRI of the brain in all the patients, or are there any patient where you leave MRI out of your imaging modalities?
So in this case, I would not like to go with the MRI brain.
And the reason for that? So it's a loco-regional case. Abhishek, it's a loco-regional case. In PET CT scan, we do not have any evidence of any metastatic disease, but yes, there is a lymph node which is less than 1 centimeter prevascular, which is in the draining area of
less than 1 centimeter, non-FDG avid.
Non-FDG avid.
Sir, I feel I will not go with an MRI brain in this case.
Okay. Rajat.
Yes, sir. Yes, sir. I will go with MRI brain till the time it was being discussed. I've already got an MRI brain done.
So what is the size of the primary?
So it's 2.5, 2.6 centimeter. So T1 lesion.
T1C. Okay. So the guidelines are basically for stage 2 onwards for MRI brain. But I think so for every curative setting, it's better to, do a MRI brain because, later on you can have some, if, down the line, if you have
I would like to go for an MRI brain if the patient is symptomatic. Otherwise, I will not go for it.
So you are not wrong, Abhishek. So because the guideline says that if it is a less than 3 centimeter peripheral lesion, so then you can omit MRI brain because the chances of MRI brain metastasis is very less in this case. So, but the thing is that here is a lymph node which we are seeing, it has been reported as non-specific. So I do not know, because these kind of reports, they come to us on a daily basis, and which report you have to think that it is significant or non-significant. So it is something which is not clear till now. So Manish, what is your take on that? So will you take a T1 lesion with this non-specific lymph node as a significant one or non-significant one?
So see, with the T1 lesion which are solid less than 1 centimeter, the possibility of them throwing a lymph node in mediastinum if the PET scan is negative is extremely low, right? And if this is a solid lesion with PET negative mediastinum, the probability of having brain lesion is extremely low. We can skip that. But yes, for practical purposes, I am doing MRI brain in all my cases.
Okay. So I think the consensus here is that yes, in a T1 lesion with a node negative status, few will be doing MRI brain, few will not be doing MRI brain. But like these days, with a medico-legal such a strong intention of everyone to sue you, so I think MRI brain is something which I will be considering in all my patients who are going ahead with a loco-regional therapy. So another question is whether you are going to go ahead with the invasive mediastinal staging or not.
So peripheral lesion less than 3 centimeter, I think EVAS is not necessary and it can be done on table. But even in this case, I think there's a prevascular node. You cannot access that prevascular node with the help of EVAS. You need to have thoracoscopy to access that prevascular lymph node. But yes, 3 centimeter, less than 3 centimeter lymph tissue size, tumor size, peripheral bronchoscopy and mediastinoscopy, they can be done on table. You can skip that before doing surgery.
Okay. So Venkat.
Yes, sir.
So what is going to be your approach in this? MRI brain, EBUS.
Yes,
So I think
MRI
these
brain,
are the two most important investigation, and we talk about these investigation day in and day out. And so probably you will be the best person after writing a book and after so that how should we proceed with that?
so the chapter on lung cancer was written by you only. So in that book, it is written that definitely in all the cases of Nsclc where it is more than stage 1B, we need to do the brain MRI. So because it is only one case that is going to cause a lot of headache, and when it is recommended, it is better to do. So in stage 1B, from 1B onwards, definitely MRI brain I will do, and invasive pulmonary mediastinal staging, yes, it is to be done before, because this patient, keeping in view of the performance status and the size of the lesion, looks like a surgical candidate, so it should be done.
So do you consider it as a peripheral lesion?
No, sir, it's a central lesion. In the CT scan, we can see it in the inner one third of the lung parenchyma. So looks like a.
So probably then this stage 1A, 1B guidelines for mediastinal staging, I think then it is gone. So we have to proceed with mediastinal staging in this patient, because it seems to be a central lesion.
Yeah.
So this we have already discussed. So here the NCCN guideline says in stage 1A you can directly like do PET-CT scan, and if it is a you can consider pathologic mediastinal lymph nodes evaluation, but it is not mandatory, so it is not recommended. But if you see in stage 1B onward, so it is definitely recommended, and pathological mediastinal lymph node evaluation, and you also should do brain MRI with contrast. So in this patient, US showed no enlarged mediastinal lymph nodes, medically fit, patient underwent surgery. So this was the histopathology report. Final staging was PT2N1. So which turns out to be stage 2. And the Priyanshu, so what do you think that that they have reported it as N1? So is it a adequate lymph nodal dissection which has been done for this patient? So we have a complete histopath report. So the margins are negatives.
Looks like an adequate, sir. They've sampled up to 11 stations, 11, 12, I think. So it looks like adequate.
Okay. So Venkat, can you just throw some light on what is called an adequate lymph nodal dissection, and is it the adequate lymph nodal dissection?
So in lung cancer, at least 10 lymph nodes from the has to be present in the specimen after lobectomy, and it should cover reasonably both all the stations of the lymph nodes. So this looks like a reasonable lymph node dissection with covering from station 5 to station 11 and more than 12 lymph nodes. So yeah.
Okay, Abhishek. So So what is going to be your approach in this patient? So this patient is having a PT2N1 disease, adenocarcinoma, all margins, they are uninvolved. So adequate lymph node dissection has been done, and T2 was in view of visceral pleural invasion. So otherwise the tumor size was less than 3 centimeter. So what will be your approach?
Sir, adjuvant chemotherapy.
Okay. Are you going to do any molecular markers for this patient?
No, sir.
So adenocarcinoma, you are not a very big fan of ADORA.
Sir, T2N1, this I don't think we have a role of, we don't have to do any molecular marker till now.
Okay.
Till
So,
till this nodal staging.
So Rajat.
If he has a recurrence, then if he has a recurrence after adjuvant, then I will go for a molecular marker testing.
Okay. Rajat.
Yes, sir.
Are you here?
Yes,
Manish?
sir. Am I audible?
Yeah, Rajat, you are audible.
So I have already got EGFR done.
So you are very fast.
Yes, sir. Yes.
So you have support of.
Rajat sir, is it positive or negative?
It is Del 19. It cannot be negative in a AstraZeneca supported symposium.
No, it is negative only. Then we will ask about the positive scenario. So Rajat, so T2N1 and you have done EGFR testing, it has come out to be positive. Suppose if it is negative, so are you going to do any other testing also, like mentioned over here, ALK, PDL1, ROS, NTRK, BRAF? Are you going to do those testings also?
So I will do a PDL1 and I will do a EGFR. These are the two that I'm going to do. Yeah, as of now, these are the.
Okay, so why not others? So I understand that there are no trials suggestive of improvement in outcome with any other targeted therapy, but at one go, if you are going ahead with a molecular testing, so if you go along with the EGFR other molecular testing also, if it comes out to be negative at this point of time, so you know the results pre-handed at the time of progression, then you can start immediately with the whatever target has come positive, rather than again searching for the same.
Yes, I agree. But then since there is no validation of other molecular tests as of now in a stage 2 disease, what I do in my practice is look for only EGFR and PDL1. This approach that you're saying can be one of the approaches, but then all this testing can be done later also once the patient becomes metastatic, if at all he does. And also in a stage 2 disease, I hope that I'm able to offer cure to the patient. So I'm not really looking at a metastatic disease straight away as of now.
Okay. So I asked this question to Dr. Aparna. So if you are doing molecular testing, so are you going to do it on the pre-surgical biopsy tissue or post-surgical resection tissue? And if there is some reason behind that, so what is that reason? So Manish, so you understood my question, na Manish?
इसको चुप कराओ.
Manish, are you here? Venkat?
So you are asking whether it's better to do the molecular testing
On
in the biopsy or the resection specimen,
or a resection specimen.
So it's same like ER, PR, HER2 testing. So once we know the results on the biopsy, there's no point in retesting. It will add to more confusion only. And anyway, we are doing on few cells. It's not like we are assessing the tumor heterogeneity. So once we are having the report on the biopsy block, there's no point in checking the resection specimen.
Okay, so I totally agree. So it's the amount of tumor.
Praveen, I want to ask you one
This may
thing.
be a
Sorry
issue
to
when you-
sorry to interrupt. I want to ask you one
Yeah,
thing.
yeah, please.
In this case scenario, if it turns out to be EGFR positive,
Mm-hmm.
will it change the management post surgery?
Yeah, it will change the management. So there is a ADORA trial, so which is of adjuvant osimertinib in stage 1B, 2, and 3 patients, where after the adequate treatment, the standard of care treatment. So these patients, they were tried against placebo and osimertinib. So 1:1 fashion, they were randomized into osimertinib and placebo, and there the disease-free survival is better with osimertinib adjuvant. So and the
We have
hazard
the OS
ratio.
data, sir, or not?
No. The OS data is still not there, but the hazard ratio is very, very significant. So the hazard ratio is 0.12.
Okay.
So we will discuss about it. So I think now we have to move forward. So EGFR mutation positive. I think we will leave these questions. So Venkat, so what do you think that these days, are there any is there any role of post-operative radiotherapy in early stage resected non-small cell lung cancer? Maybe we can take it stage wise, stage 1 or 2, then stage 3. So stage 1 or 2, is there any role of post-operative radiotherapy?
So one of the most important indication, like in other cancers, is margin positivity. And the other indication is being I'm not sure, sir. I'm sure about the margin positivity.
Yeah, that's the only indication.
So for lymph nodal status, I think it is not an absolute indication nowadays. So if you had a result from lung art trial that clearly showed that if you have lymph node positivity, the post-op radiation is not going to benefit much to your patient. So only thing which have benefit, I think, is margin positivity and nothing else.
Okay.
In early stage, I think that's the only thing.
So I think the consensus is that stage 1, 2, no role of post-operative radiotherapy. If there is complete resection of the tumor, R1, R2, yes, definitely we have to give radiotherapy. In stage 3, or if we talk about the nodal status, so nodal status, N1 no role, N2 lung art trial has shown. So there is not much of role for adjuvant RT. But N3, if histopathology shows N3 or multi-station N2 with probably with EC, lot of mediastinal burden, so which is exactly, it is not a scenario which we come across in our daily practice, because most of our patients, they are adequately staged pre-operatively, and the chances of getting such a huge burden of disease in mediastinum is very, very less. So the role of Sbrt in early stage Nsclc. So I think those patients where the comorbidities are there, so there we can consider. So what is your take on Sbrt, Rajat? Priyanshu, so role of Sbrt.
Sir, patient who cannot undergo surgery for any comorbidities, or who have a poor pulmonary function test, and who have expected FEV1 after resection is not satisfactory, and so in that patient Sbrt can be given.
Okay, so this patient, stage 2 adenocarcinoma, EGFR mutation, and as per Rajat, it was not DEL19, it was L858 beta. So what should be the next approach? So I think we will start with Manish. So whether you will proceed with adjuvant chemotherapy, adjuvant osimertinib, or adjuvant chemotherapy followed by osimertinib. So what will be your approach?
So this is N1 disease, and I think we will proceed with chemotherapy followed by adjuvant osimertinib for this patient.
Okay, and for how long you will continue osimertinib here?
So at least till the time patient has toxicity, or 3 years.
Okay. See, the thing is, there are few questions which are still unanswered. So if we see the previous trials, So like Radiant, Evans, or Ctong trial. So there was a different trial schema which was considered in these trials. So there erlotinib or gefitinib was tried against chemotherapy. So the chemotherapy was not received in the experimental arm. Here, so the benefit of osimertinib was seen in both the groups, whether the patient has received chemotherapy or no chemotherapy. So Priyanshu, so what is your take on in discordance of these trial results? So we have seen in Ctong, so yes, there was a DFS advantage and hazard ratio was 0.6 in Ctong trial, but later on it did not turn out, it did not translate into the overall survival advantage. So is the fate going to be different for osimertinib? What do you think about it?
Sir, with the hazard ratio of 0.17, I think so. I'm expecting a favorable OS profile also. And the second, as you already mentioned, was that the difference in the trial design also. And, definitely osimertinib, we all know, is better with respect to CNS penetration also. As we all know that in this trial also, there were less of a loco-regional relapses as well as, better CNS control also. And we all know that CNS is one of the, sanctuary side also. So I think so in the long run, this, better efficacy and better CNS penetration would give us a favorable OS data also.
And what will be the status of chemotherapy in your patient? So will you go ahead with chemotherapy? See, we have seen the benefit of adjuvant osimertinib was there with or without chemotherapy. And the hazard ratio was almost quite similar. So 0.17 and 0.22, I think so it was quite similar. So will you be considering, so one way of proceeding with it is that you can just tell the patient we are saving you from chemotherapy and we proceed with osimertinib only, or the patient should continue with the standard of care treatment and after that only osimertinib should be started.
Sir, I would prefer to give 4 cycles of adjuvant chemotherapy provided he is platinum eligible and we can tolerate and PS is fine. Then I would like to give a, we have 5% advantage according to this LACE meta-analysis. I don't want the patient to, 5% is a big OS advantage, I would say. So I don't want the patient to miss on that.
Yes, so especially
until the data on OS is mature.
Especially in those patients who have node positivity. So the patient, they had 5-year overall survival advantage up to 10 to 15%.
Manish, node पे तो osimertinib भी काम करेगी ना?
Sorry, LACE meta-analysis. The later stage.
Sir, OS data अभी osimertinib का हमारे पास है नहीं, तो we are not very sure.
10 to 15% survival advantage. So few of the patients, they are cured by chemotherapy.
अभी जो guidelines, what the guidelines say that you can even observe these patients.
The later stage.
So I think when we talk about any drug in the adjuvant setting, so you have to see the tolerability of these drugs also. And osimertinib, it has shown such a good tolerability that it is not exactly close to our hormonal therapy. But if we talk about chemotherapy and this, so it is very well tolerable as compared to chemotherapy. But this is exactly in the trial data. So we have seen in the metastatic setting, so there were some real world evidence also. So where the incidence of cardiac issues, so they were close to 8 to 9%. So I'm not sure whether, so I think we have to wait for the complete analysis of osimertinib, and we have to see not only the efficacy analysis, we also have to see the safety analysis of such a drug. And nobody is sure of whether it is delaying the reoccurrence or whether it is preventing the reoccurrence. So I'm not sure of it. So see, in Ctong trial, what we had seen was that the DFS advantage did not translate to overall survival advantage. But yes, the DFS hazard ratio was 0.6. So it was never such a less hazard ratio with erlotinib. So probably it is osimertinib which has to give the answer, and the maturity of data is something which we will have to wait for. So coming to, so these things we have already discussed. So this is the LACE analysis which showed the 5-year OS advantage of 5.4%. and this is according to the stage. The advantage was more with the stage 3 disease, and this was the ADAURA trial, and we can see over here that 2/3 of the patient, they were stage 2, 3A, which was in the primary endpoint analysis, and 1B stage was close to 1/3 of the patient. And here we can see the primary population, the hazard ratio was 0.17. And in the overall population, the hazard ratio was 0.2. So these were the previous trials. So the radiant DFS, again, the DFS advantage initially it was there, but after stopping erlotinib, this advantage, this dipped down, and both the curves, they crossed each other. So if we see here, it is the ADAURA, so which shows that there is wide separation of the DFS Kaplan-Meier curves. So this is the CTONG DFS curve. So initially it's separated, then one second, please. So then later on they come near to each other after stopping the drug. So this is something which we have to see in the ADAURA also, so that the drug is being continued for 3 years. So we have to see after a follow-up period of 3 years that the curves are still separated, what is going to be the OS advantage with the drug. But yes, at the face of it, we have to take it very, very seriously, and osimertinib is definitely a contender as an adjuvant targeted therapy. So talking about the CNS involvement, as rightly pointed out by Priyanshu, the CNS reoccurrence was very, very less with the osimertinib in ADAURA trial. We can see only 1% of the patient who progressed in CNS vis-a-vis 10% with the placebo. So CNS is a sanctuary site. So coming to the final question, so is ADAURA practice changing? And I will take opinions from all of you. So we will start with Venkat. So is it going to change your practice? So now tomorrow, so you have a patient in your clinic who has underwent surgery and an EGFR mutated stage 2 patient. So will you give the patient post chemotherapy osimertinib for 3 years? Patient has finances, no issues regarding the finances.
So I will not use in all the patients, but those patients after explaining the chances of recurrence and who are really concerned about the recurrence, I will use it. Otherwise, I will save it for the metastatic setting.
Okay, so you are not convinced with the ADAURA data?
As of now, I cannot use in my patients. So,
no, but the patient has all the finances and it is FDA approved also. Venkat. Yeah. So patient can ask you that, is there any drug which you can give to prevent my reoccurrence? Yeah, so I am mentioning the same, sir. So in those patients who is really concerned with the recurrences, because whenever I do explain the recurrence rate and all, even in the early and local advanced cancers. So in those patients who are really concerned, definitely I will use, who have finances. Yes. Okay. Manish.
My answer is yes. The data and the drug which is having such a good hazard ratios for PFS, I think we will have the overall survival as well. And please do remember that being progression free in CNS is extremely important, which has been shown in this ADAURA trial.
So Priyanshu.
Yes, sir, it's a practice changing. The only issue constraint being cost. So, but we are actually doing EGFR in early, Nsclc now, which we were not doing earlier. Although the subset of patient in my practice who are early stages, around 10% at the max. So the overall patient number is also less, but definitely it is practice change.
Okay, Abhishek.
Sir, I have rarely seen a patient who has such early.
But you have a patient in your clinic tomorrow morning. So I'm sending you one patient who is post resection setting.
I'll offer him, but then I seriously doubt.
No, but are you? So first of all, to convince a patient, you should be at least convinced. Yes, is it a practice changing concept?
It is a practice changing concept, sir. Definitely, even if it offers a DFS, then I am okay with it. But then I seriously doubt whether it will give some OS or not.
Okay. Okay. Sir Rajat, final words from Rajat. So I think Rajat is not here.
Rajat is very busy.
He's always busy. So I think after seeing the results of ADAURA, yes, see all the trials, they have some criticism. So all the trials, they have some limitation. So but it was a very well conducted trial, and it has been done. So they have taken both the arms where the chemotherapy has been given or where the chemotherapy has not been given. So they were well justified with all these things. And even after that, if they are showing a hazard ratio of 0.17, so I think there was 83% reduction in risk of progression or death. So apart from that, if you see the DFS at 2 years timeline, so it was almost doubling of the DFS. So 44% versus 90%. So this is huge. So if we see with the placebo, so the median DFS was close to 18 to 20 months. And at 2 years, if with osimertinib, so the patient is having disease free, almost 90% of the patient are disease free. I think in a later time. So this is very, very compelling. The data is compelling, and it will turn out to be having a overall survival advantage. And similarly, NCCN guidelines also recommend chemotherapy followed by osimertinib in those who are having EGFR mutated lung cancer early stage. With this, I would like to conclude the panel discussion, and I would like to express my vote of thanks to Dr. Manish Sharma and AstraZeneca for giving me this opportunity. If there are any questions, I think we can take up and we can discuss about it.
Thank you, Dr. Praveen. So it was extremely nice panel discussion. I thank you, Dr. Arpana, for being here, and Dr. Venkat for taking the session on metastatic Nsclc. All my colleagues, Dr. Priyanshu, Dr. Abhishek, Dr. Rajat, I thank you, all of you. I think this is an ever-changing field, oncology, and it is a rapidly changing field, both in the molecular terms and in the targeted treatment and immunotherapy terms. We will conclude the session here. I thank AstraZeneca and Intas for supporting this session. Good night. Thank you so much for being here.
Thank you so much, sir. Good night, sir.
Good night, Dr. Manish. Good night, everyone.
Thank you.